Good morning. I would like to thank SAGES for giving me the opportunity to share our work with you today. We have no disclosures. Esophagectomy remains the treatment of choice in patients with locally advanced esophageal cancer. During this procedure, a gastric conduit is typically utilized. During tubulization of the gastric conduit, vagal nerve damage often occurs, as well as disruption of the gastric neuromuscular network. This can lead to postoperative gastric conduit dysmotility and pyloric dysfunction. Post-op delayed gastric emptying is seen in 15 to 30% of patients and can lead to aspiration pneumonia, anastomotic stenosis, and/or an anastomotic leak. To reduce the risk of conduit dysfunction, intraoperative pyloric procedures can be utilized. These include pyloroplasty, which is typically performed in a standard Heineke-Michelwitz fashion, pyloromyotomy, which is performed by incising the serosa and dividing the pylorus muscle with cautery, Botox injection, which is typically performed by injecting 100 units of Botox in 10 milliliters of solution, and it's usually injected to 4 quadrants around the pyloric ring. Despite the use of pyloric drainage procedures, postoperative endoscopic interventions are often performed due to symptoms of conduit dysfunction. These can include anastomotic dilations and further pyloric interventions, such as dilations and/or Botox injections. The aim of this study was to compare the rates of postoperative endoscopic interventions within the first 6 months after minimally invasive esophagectomy for the different intraoperative pyloric drainage procedure types. This was a retrospective study using our IRB-approved prospective esophagectomy database. 146 patients between 2008 and 2015 who had 3-hole or Iber-Lewis esophagectomy for esophageal cancer were included. Each patient had 1 of 4 pyloric interventions at the surgeon's discretion. No procedure, pyloroplasty, pyloromyotomy, or Botox injection. Our endpoints included the rates, types, and timing of endoscopic interventions during the initial 6 months after esophagectomy. These are our patient characteristics. As previously said, 146 patients were included in the cohort. The greatest percentage of patients received a pyloroplasty, followed by Botox injection and pyloromyotomy. As you can see, gender, age, BMI, and type of carcinoma did not differ between the groups greatly. Most patients in the cohort had a 3-hole esophagectomy. Of those that had a 3-hole, most had either a pyloroplasty or a pyloromyotomy. Of those that had an Iber-Lewis esophagectomy, the majority of patients had Botox injections. This was due to the fact that at our institution, Iber-Lewis esophagectomies have become more common, as well as Botox injections. These are our overall endoscopic intervention results. The blue bars represent the percentage of patients requiring any endoscopic intervention, while the red bars represent more than one intervention. 26% of all patients required a postoperative intervention, with the greatest percentage being in the Botox group and the pyloroplasty group. 16.4% of patients required more than one intervention, again, with the greatest percentages of patients being in the Botox and pyloroplasty groups. We performed logistic regression to do pairwise comparison of the groups. The results showed that the odds ratio of having any endoscopic intervention was greatest for the Botox group when compared to the pyloromyotomy group and the pyloroplasty group. We also looked at the timing of that first intervention for patients who had at least one of the interventions within the first 6 months post-op. The median days to the first intervention was 78.5 days, or about 11 weeks. This did not differ greatly between the patients that had anastomotic dilations and those that had pyloric interventions. We also found that only 2.7% of patients required an intervention within the first 30 days. This intuitively makes sense for anastomotic dilation, since anastomotic strictures usually take time to perform in the postoperative period. However, for pyloric interventions, this may suggest that pyloric edema, which typically occurs early in the postoperative period, may not be a contributing factor to delayed gastric emptying. When looking at the types of endoscopic interventions, we looked separately at those that had anastomotic dilations and those that were pyloric interventions. Here are the results for anastomotic dilations. 19.2% of patients required at least one dilation, and the pyloroplasty group had the greatest percentage of patients requiring a dilation. 12.3% of patients required more than one dilation within the first 6 months. And again, the greatest percentage of patients were in the pyloroplasty group. Here are the results by pyloric interventions. Few patients required pyloric interventions at 11% in contrast to anastomotic dilations. And here the Botox injection group had the greatest proportion of patients requiring pyloric interventions. This may suggest that Botox injections do not last long enough to provide relief from pyloric obstruction, and further dilations or injections may be needed. A small percentage of patients required more than one pyloric intervention, and though 19.5% of patients who had Botox required a pyloric intervention, only 4.8% required more than one intervention. We also looked at the rate of postoperative interventions between the two different groups of types of minimally invasive esophagectomies. The blue bars represent the results for the 3-hole esophagectomies, and the red bars represent the results for the Ivor-Lewis esophagectomies. Here you can see that the 3-hole esophagectomies had a greater proportion of patients requiring postoperative interventions, and this held true for anastomotic dilations and the pyloric interventions. We then adjusted for the fact that when compared to 3 holes, the Ivor-Lewis patients received Botox injections more often and were less likely to require postoperative interventions. And we used zero-inflated press-on regression analysis to adjust for esophagectomy type and determine the incidence rates for undergoing more than one postoperative intervention. Here are our results. Again, we did pairwise comparison of the groups. Interestingly, the Botox group, which had previously shown to have increased odds ratio for having any postoperative intervention, now showed that when adjusting for minimally invasive type, they had a significantly lower rate of having more than one intervention compared to the pyloromyotomy and pyloroplasty groups. This also held true for the group that did not have any pyloric procedure. In combination, this data shows that the odds of having a postoperative intervention is greatest in the Botox group, but the pyloroplasty and pyloromyotomy groups had higher rates of needing multiple interventions. This suggests that creating an incision on the pylorus when performing a pyloroplasty or a pyloromyotomy may cause conduit dysfunction to last for a longer period of time than when injecting Botox or when not performing a pyloric procedure at all. In conclusion, our data did not show superiority of any particular pyloric procedure in preventing endoscopic interventions. Pyloric Botox injections demonstrated a trend toward requiring a secondary intervention. However, when adjusting for esophagectomy type, the Botox group was less likely to require more than one intervention. Further research is needed to determine if the choice of intraoperative pyloric procedure type significantly affects quality of life, morbidity, and overall prognosis in these patients. Thank you.